Okay, so this is where we left off. I want to pick back up with talking about these structures of the respiratory system. And so where we were is all the way down here. So we're down here at the level of the alveoli, small microscopic structures. And like we had said before, this is really important because this magical thing's happening here. So this is our site of gas exchange, which is very important. And so how does this happen? So one of the things that we need to talk about in regards to that is the respiratory membrane. And so what we have here is this three-layered membrane that occurs between the alveoli and the capillaries that surround that alveoli. So if you remember, sorry, I keep backing up, but when we look at this, we've got each individual alveoli surrounded by capillary bed. And so this is where gas exchange is going to occur. And what we see is if we kind of blow it up, this is what we're looking at. Here's our alveoli. And if we enlarge that, we can see this three-layered respiratory membrane. And so what happens is we've got, here's my alveoli, okay? And we know that the alveoli is formed by simple squamous epithelium, okay? And then we know we've got the capillary that's basically traveling right beside the alveoli. And the wall of the capillary, if you think back to blood vessels when we talked about that, what's specific about capillaries is that they were only one tunic, and they only had tunica intima, and that tunica intima was formed from simple squamous endothelium, right? So we've got two structures here, both with very, very thin walls, and we end up with this basement membrane in between. So we'll kind of we can add another line in there too. This is their fused basement membrane, which is basically going to kind of join together both of those structures. And this is how diffusion occurs, okay? Because we've got very thin wall of the alveoli here. This is capillary here. And as we breathe air in, that oxygen is going to enter the alveoli, and then it's going to diffuse into the capillary down its concentration gradient, and carbon dioxide is going to do exactly the opposite. So carbon dioxide that's traveling in that capillary is going to diffuse across those very thin walls into the alveoli so that we can exhale it out to the environment. Okay, so three layers. One layer is the alveoli's wall or alveolar epithelium, which is simple squamous, fused basement membrane in between, and then capillary endothelium, which is also simple squamous. And the fact that carbon dioxide and oxygen are both going to move by simple diffusion, which means they're going to move from their area of high to their area of low concentration, right? Because diffusion is passive, and so it's going to have to go down its concentration gradient. And that's going to come into play in just a little bit. We're going to talk about that a little bit more. Okay, some big picture anatomy of the lung. So this would be kind of more gross anatomy. Apex of the lung is going to be the pointy part at the top. That's going to be the apex of the lung. We've got the base of the lung, which is going to be the broad part at the bottom here and here. The hilum of the lung, if you take the lungs and you kind of turn them so that you can see the medial aspect of the lungs, what we're going to see is this area through here where basically we've got vessels that are going to come in and out. So like the primary bronchus, as it comes down and it splits and it enters the lung. We've got bronchial arteries and veins. We've got pulmonary arteries and veins. So all of those structures are kind of condensed in this little area, and that's called the hilum. Another thing too is the left lung has two lobes, So if you look on here, we've got kind of this lobe on top here, which is going to be our superior lobe, and then we've got another lobe on the bottom, which is going to be the inferior lobe. And separating the two is the oblique fissure. Okay, so it's kind of this line in between those two lobes that's going to separate them. And then we also have this structure, or this little indention in the lungs, that's called the cardiac notch. And so that's going to be like this area here. And so we've got that because the heart, we know, is angled to the left. That left ventricle takes up so much more space, and it kind of makes that right lung indent a little bit. On the flip side of things, on the right lung, we've got 3 lobes. So that's a little bit different. Right lung has got a superior lobe here. It's got a middle lobe, which is going to be right in between, and then it's got an inferior lobe here. Okay, so 3 lobes on the right, only 2 lobes on the left. And on the right side, we've got 2 fissures then that are going to separate those lobes. So one of them is going to be horizontal fissure that kind of goes straight across. The other one is an oblique fissure because it's more at an oblique angle. Okay, so why do we have this happen? Well, the heart takes up more space on the left side of the body, so the left lung is actually going to be a little bit smaller than the right lung. And if you look at lung tissue, it's mostly air. Like, it's very spongy. I think we talked about this before. It's not at all what you see in cadaver lab. Those lungs are very dense because they've absorbed so much solution, but real lungs are very airy and spongy, and we call lung tissue stroma, and it's basically elastic connective tissue. It's got these kind of air spaces in between elastic lung tissue, so it's very light and spongy. In terms of pulmonary circulation to the lungs, this is a review. This is some of the information that you already know from the heart anatomy when we went over that. But we know that we've got pulmonary arteries that are going to travel from the heart to the lungs, right? And pulmonary circulation is different. It's going to be oxygen poor. So that's our oxygen poor blood there, traveling to the lungs, and specifically the alveoli, where we're going to have gas exchange. And then pulmonary veins are going to return oxygenated blood back to the heart. And we're going to see all that being dumped into that left atrium. And so oxygen-rich veins here. So pulmonary circulation is a little bit different. And again, I just remind you that the pulmonary arteries and veins are going to enter and exit the lungs through the hilum. So like this area here where you have these vessels coming in and out are going to be the hilum. Now we do have bronchial circulation to the lungs. So you can think of this lung circulation as very similar to what we had in the heart with coronary, where the heart was filled with blood, but it actually didn't get a lot of nutrients from the blood that it contained. Pulmonary circulation is the same way. So pulmonary circulation is primarily to send out to the body, but the lungs themselves need a blood supply. And so we have that through bronchial circulation. So what we have here are some bronchial arteries that are going to branch off directly from the aorta. So if we look, here's our aorta, and we're going to see these first few little tiny branches here that are going to travel down into the right and left lungs to supply them with oxygenated blood. Venous blood is going to drain from the lung tissue back to the heart, and it actually drains through in a couple different ways. It can drain through bronchial veins, which are going to drain lung tissue and take it back to the heart, or it can actually drain through pulmonary veins. So we kind of have this double way of getting venous blood back to the heart from the lungs. But the difference there is the fact that bronchial arteries supply the lung tissue with arterial blood. Okay, lungs are innervated. So we have this whole aspect of sympathetic versus parasympathetic, and the same is true for the lungs. We see it here as well. If you recall, parasympathetic is rest and digest. So we're basically laying on the sofa, not doing much. How is our breathing? It's slow. We don't have much going on. So what we see in that case is we see bronchial constriction because there's not a lot of air movement that needs to happen. On the flip side of things, oh, here's your rest and digest here, right? On the flip side of things, let's say we have sympathetic activation, and what's happening there? We need to run away from the bear in the parking lot, right? So we need to dilate our airways so that we can move a lot of air in and out. So we're going to see bronchial dilation with sympathetic activation. So one of the things I would like to point out here is, remember for just a second with blood vessels. What happened when we had sympathetic innervation of blood vessels or sympathetic activation of blood vessels? What was the response? Did the vessels vasodilate or did they vasoconstrict? So blood vessels vasoconstrict with sympathetic activation. So it's opposite from what you see in the lungs. Okay, that's a great question. That's a great test question. So with sympathetic activation, blood vessels are going to vasoconstrict. Airways are going to vasodilate. Okay, they have opposite responses. So something to keep in mind. Also, too, we can talk about the pleura of the lungs. We know that lungs have this double-layered serous membrane that we see, parietal pleura. We know pleura is specific to lungs. Parietal pleura is going to line the cavity that the lungs reside in. So it's going to line the thoracic cavity. And then on the flip side of things, we've got the visceral pleura, which is going to be lining the organ themselves. So it's going to actually be adjacent or right on the outside of the lung itself, because viscera means organ. And so that leaves the space in the middle. It's a very similar setup to what we had with the heart, right? So we had this space here where we have fluid. So we have kind of the serous fluid located in this pleural space. And the same thing is true in the lungs. We've got pleural fluid, and it's going to reduce friction. So every time our lungs expand and contract, it helps to reduce friction in their movement. And then also, too, it creates some surface tension. So lungs are really spongy. And if you don't have something that suctions them out to the walls of your thoracic cavity, they are actually going to just collapse. Okay, so we have some surface tension that's built up here that actually kind of pulls those lungs out against the walls of your thoracic cavity. So, but that's pleura, and that should be a little bit of review. We've talked about pleural membranes or serous membranes in different capacities throughout the semester. This just applies it to the lungs. Okay, when we talk about physiology of respiration, we're basically to the point now where we're at pulmonary ventilation, so getting air in and out of the lungs. And this occurs in two phases. Inspiration is the process of pulling air into your lungs, okay? And then we have expiration, which is the process of moving air out of your lungs, okay? This is also known as breathing. So we're going to talk about how this happens. So breathing, or this pulmonary ventilation, is all based on two things: pressure and volume. Okay, so we're going to talk about how this relates to the lungs. So one thing to keep in mind is that when we talk about respiratory pressures, they're always relative to atmospheric pressure, which is basically the pressure of the air around you in the atmosphere pushing down on you and everything around you. Okay, so we base this on an atmospheric pressure of 760 millimeters of mercury. It's just like blood pressure. Pressure is always measured in millimeters of mercury. So atmospheric pressure at sea level is 760 millimeters of mercury. Okay, that's a number you need to know. There's our baseline. Okay, there's a couple other important pressures. So we also have what's called intrapulmonary pressure. And so, what we see here, intrapulmonary. So this means inside the lungs, okay? This is actually the pressure in the alveoli, okay? Within the alveoli. So this is going to be this pressure here inside the lungs. This is what we see. Okay, here's our intrapulmonary pressure. Now, this is going to increase and decrease as we breathe, but ultimately, because this is continuous, inside our lungs is continuous with outside of the body, it's always going to end up equalizing with atmospheric pressure. Because basically, we can create an increase or a decrease, but over time, it's going to end up equalizing with the atmospheric pressure on the outside of our body, okay? Because this is a continuous passageway between the outside and the inside of our lungs, okay? So that's one. The second pressure that's interesting is intrapleural pressure. Intrapleural pressure. And so what this is this is actually the pressure that's in the pleural cavity. So what do we mean by pleural cavity? If you think back about what we just talked about, our pleural cavity is basically this space here in between the lungs and the walls of the thoracic cavity. Okay, it's that space in between. It's filled with fluid. But what we see here is that our intrapleural pressure is always going to be about negative 4 millimeters of mercury. So it's always about 4 millimeters of mercury less than intrapulmonary pressure. Okay, so as our intrapulmonary pressure varies up and down when we inspire and expire, our intrapleural pressure is going to vary as well, but it always stays a little bit below the intrapulmonary pressure. And so what this does is this creates a negative pressure. So it's always going to be a negative pressure, which is actually a suctioning. And so this is a pressure that, like I talked about, the lungs are really soft and squishy and airy, okay? So they need some help suctioning them out to the walls of the thoracic cavity. And this is the force that does that, okay? This is the pressure that does that. So intrapleural pressure, this is the pressure in the space between the lungs and the wall of the thoracic cavity. Okay, and then transpulmonary pressure. So transpulmonary pressure is going to be the pressure difference between the two. Okay, transpulmonary pressure is going to be the difference between the intrapulmonary pressure, or the pressure in the lung itself, and the intrapleural pressure, which is the pressure out here in the pleural cavity. Okay, and so what we see here is that this pressure difference keeps the lungs expanded. This is that negative pressure difference. The fact that the intrapleural pressure is always going to be slightly more negative than the intrapulmonary pressure, because that creates the suction that holds the lungs out. Okay, so what happens when we create, problems with that barrier or that intrapleural pressure? If you have situations where you have someone who has a knife wound that basically pierces through the parietal pleura, or you have a rupture in the visceral pleura, what we end up having is the intrapleural pressure, this pressure here, where normally that would be about a -4, right? If we have something where we've pierced through here and we've even pierced through here, now we've got pressure equalizing. There's no way we can maintain that negative pressure. So this creates a scenario where we have what's called a pneumothorax, or air gets in this pleural cavity. Typically there's not air there. Okay, there's fluid. There's fluid to reduce friction, but there's not air. But if we disrupt this membrane here or this membrane here, it gives the pleural cavity a chance to equalize in pressure with either the outside world here or the intrapulmonary pressure here, which is basically equal to the outside as well. And we lose the suction, is kind of the whole point of this. We've lost this -4 millimeter of mercury suctioning force, and that lung is basically collapsed. So it's going to collapse into like this tiny little shriveled up lung because there's no more suctioning to hold it out to the walls of the thoracic cavity. On the flip side, if you look at this side, there was no injury on this side, and we've maintained our -4 intrapleural pressure there, and so we've maintained our suctioning. So on this side, we've got a nice, nice fully expanded lung, and it's doing its job. So I'm talking about this just to illustrate the fact that we've got two separate pleural cavities. So like the right lung is in its own pleural cavity, the left lung is in its own pleural cavity. So something that happens to one pleural cavity doesn't always affect the other pleural cavity. So you can have a pneumothorax with a collapsed lung on one side, and the other lung is still, able to do its thing, and it's still breathing. It can keep you alive until you can get to the hospital. Okay? So how do pressure and volume relate here? So basically, what we see is this inverse relationship between pressure and volume. So meaning that as volume of the thoracic cavity increases, pressure is going to do exactly the opposite. Pressure is going to decrease. Okay? And so we're able to change volume and pressure when we breathe in and out. And this is how we're able to move air. So how does this happen? Basically, this is during inspiration. Okay? We're breathing air in. So what happens here is that our prime mover for inspiration is our diaphragm. Okay, so remember that we had that dome-shaped muscle that separated thoracic cavity from abdominal pelvic cavity, right? And so what happens when you breathe in, the diaphragm, instead of it being dome-shaped, which it is at rest, it actually flattens out a little bit. Okay, so here's our thoracic cavity. Okay, and we just went from a position kind of like this at rest. Okay, so maybe this first one is us at rest, and then the diaphragm contracts and it actually descends and it flattens out. If you compare these two, what just happened to the volume of our thoracic cavity? So like this space, let's color it. Like this space in here, okay? Comparing this to all of this, okay? So what just happened? What just happened to volume? So basically, comparing the two of these, our volume just increased. We had an increase in volume, okay? Diaphragm contracts, it descends. Our ribs, if you feel your ribs when you take a deep breath in, our ribs expand, and that further, our ribs move upwards, and that further expands our thoracic cavity, okay? So our volume is going to increase. What do we know has to happen? According to Boyle's law, If volume increases, pressure has to decrease. So, same thing is true here. Here we just saw an increase in volume when we inspired. What's going to happen to our pressure? So we know pressure is going to decrease. Okay? So if we have, let's draw this picture again. Here's our thoracic cavity, okay, with our diaphragm down here. Here we have pressure decreasing inside our thoracic cavity because we have an increase in volume when we breathe in, okay? So what happens is our pressure is going to decrease below that of atmospheric pressure around us. So out here in the atmosphere, we're going to have a higher pressure than inside our thoracic cavity, okay? Air is going to flow into our thoracic cavity down its pressure gradient, okay? So that's what causes air to move in when we breathe in, okay? Air is going to move down its pressure gradient. It's going to move from its area of high pressure to its area of lower pressure, okay? Also keeping in mind too that this is just with quiet inspiration. So mainly for quiet inspiration, we have diaphragm working. Also external intercostals contract a little bit too, but really diaphragm is your prime mover for quiet inspiration. When we exercise, so you're doing hill repeats and you are really moving a lot of air, we have what's called accessory muscles of inspiration. So scalenes, sternocleidomastoid, and pec minor all play a role in elevating your rib cage so that you can pull in more air when you breathe in, when you're exercising. Okay? What happens when we expire? So what happens during expiration? So let's draw. Here's our starting picture here, and we're starting in a position of our diaphragm being flattened out because that's where we left it when we inspired. So when we expire, we have passive recoil of the lungs and our inspiratory muscles relax. So diaphragm relaxes, external intercostals and maybe our accessory muscles relax, and our rib cage goes back to normal. It gets smaller. Okay, so we went from this position to a position like this. Let's even, oh, hold on, let me, okay. Hold on, bear with me. Okay. All right, so we were here with our diaphragm descended. Now we are expiring. So our diaphragm ends up moving back up into that dome position, okay? What just happened to the volume in our thoracic cavity there? So if you look at that space again, here's our thoracic cavity. So we just went from all this space, all this volume, to this volume, right? Okay, so let's look at that. So what just happened? We decreased the volume in our thoracic cavity, okay, when we expire. And because of Boyle's law, we know that pressure and volume have an inverse relationship. So if volume decreases, what has to happen to pressure? Right? So think about it. If volume decreases, our pressure is going to increase, okay, within our thoracic cavity. That increased pressure means that it has a higher pressure inside the thoracic cavity versus atmospheric pressure on the outside of us. We know air is going to flow down its pressure gradient. So air is going to move from inside the thoracic cavity to outside the body, okay? And that's how air moves from inside the lungs outside when we expire. Okay? Volume of the thoracic cavity decreases. That means pressure within the thoracic cavity increases because of that inverse relationship, and it pushes the air out, back out into the atmosphere. Okay? So, expiration at rest, this is kind of important here, is primarily passive recoil of the lungs. Okay? So expiration is pretty much passive if you're just sitting there quietly. Okay? If you are running or you're doing hill repeats or something like that, during forced expiration, we do have accessory muscles of expiration that are going to play a role. And so with these, we see our abdominal muscles, they're going to contract and they're going to help push the air out. Also, internal intercostals are going to help depress the rib cage and push that air out of our thoracic cavity. Okay, so there's your pressure changes.